Hi, this is Hallie Stephen-Castro. I'm going to do a brief lecture on care of clients with AKI and CKD. Again, this will not take place of your reading assignment, so make sure you read the chapter 68, I believe, in your book. Thanks. The main concept for acute and chronic kidney injury is elimination. It falls under the elimination heading. There are some interrelated concepts: acid-base balance, fluid and electrolyte balance, immunity, and perfusion. The definition of acute kidney injury is just the rapid reduction of kidney function. It's an acute injury, so it has to happen over the matter of a few hours or a few days. It can cause some systemic effects, and if not corrected, it can result in death. There's a table in your book, Table 68-4, that lists the conditions that can result in acute kidney injury. Please review that. There are also some other pre-existing conditions that can lead to this, as well as just being in advanced age, such as our geriatric clients and those with other pre-existing conditions. I want to expand a little bit on the etiology of AKI. In your book, there are three distinct categories. You have pre-renal, which is usually a perfusion issue. You have lack of blood flow to the kidneys. Intrarenal, which is something going on with the kidneys themselves. Or post-renal, which is usually some type of obstruction. I do want to reiterate that dehydration or fluid volume deficit is typically the primary cause of acute kidney injury. That's why it's real important to focus your nursing interventions around hydration for your client and looking for signs and symptoms of fluid volume deficit. It's best to avoid dehydration by drinking at least 2 to 3 liters of water daily, and since having a fluid volume deficit are one of the main causes, that certainly does help with acute kidney injuries. Be aware of any characteristic changes in the urine and avoid those nephrotoxic substances. Some initial signs of acute kidney injury include oliguria, and that's defined as 0.5 mils of urine per kilo per hour or less for at least 2 hours. Also, on a urine dipstick, the specific gravity may be elevated as well. The color would be more concentrated. These are all signs of AKI. Clients who have had recent surgery or trauma are also at risk for acute kidney injury. Usually surgery clients have been NPO, or trauma clients have had a loss of volume, and that can result in lack of perfusion to the kidneys. It's important to get a thorough drug history from your client, and that includes prescription and non-prescription drugs. There are all kinds of medications that can be nephrotoxic, including NSAIDs like ibuprofen, antibiotics, as well as chemotherapy agents and things like contrast dye for CAT scans, extremely nephrotoxic. Coexisting conditions such as advanced age, diabetes, and uncontrolled hypertension or poorly controlled hypertension can contribute to both AKI and certainly chronic kidney disease. Acute illnesses can also cause an immunity-mediated acute kidney injury. With acute illnesses, we have an inflammatory response, and sometimes that inflammatory response can also affect the kidneys and causing glomerular nephritis. If a client has had any type of hypotension, shock, lack of perfusion, or lack of blood volume to the kidneys, we should be anticipating that there's going to be some type of acute kidney injury, and we should be monitoring them very closely. Hourly urine output monitoring is important for clients who have a known or suspected kidney injury, or those who are at risk for acute kidney injuries. In both acute and chronic kidney injury, there are times when the kidneys can cease functioning completely, and we need to be conscious of that and assess for fluid volume overload. Things like jugular vein distension, bounding pulses, and weight gain. Monitor the trends of your client's vital signs and watch for hypoperfusion. Things like tachycardia, hypotension or low blood pressure, and hypoxemia are all signs of hypoperfusion and can have an effect on the kidneys. It's important to monitor the laboratory values of your clients and also monitor the trends. BUN and creatinine are important labs for kidney function. And if there is some type of kidney injury, we need to monitor the electrolytes closely as well, particularly the potassium, the calcium, and phosphorus, as well as magnesium. Some of our nursing interventions would include avoiding hypotension altogether and maintaining that proper fluid balance. Watch exposure to nephrotoxic agents, monitor the lab values, particularly the BUN and the creatinine. Watch the eyes and nose very closely. Monitor drug therapy, nutrition therapy, and kidney replacement therapy if needed. Now we're moving on to chronic kidney disease. We're going to distinguish between acute and chronic. I want you guys to make a mental note of the differences between these two disorders. To compare, chronic kidney disease is progressive, it's irreversible. It also is accompanied by uremic syndrome, azotemia, which is the presence of toxins in the bloodstream, and uremia, which is urea in the bloodstream because they can't be excreted by the kidneys. There are 5 stages of chronic kidney disease, and it's all based on the GFR category, which is the glomerular filtration rate. Please review that table. It's 68.6 in your book. We shouldn't have to test you on anything specific with this pathophysiology, but I want you to be familiar with it. There are a lot of significant system changes with chronic kidney disease. The book goes into some good detail about many of those. I've listed a few here of the important ones, but I do want you to review all those systemic changes that are listed in your book. End-stage renal disease or chronic kidney disease is extremely prevalent in the United States. Over 800,000 people are being treated for chronic kidney disease or end-stage renal disease. While chronic kidney disease is not reversible, we can slow the progression. We need to control the diseases that lead to chronic kidney disease to help prevent them initially. Dietary adjustments, weight maintenance, smoking cessation, exercise, and limit alcohol use. Clients with chronic kidney disease should get a daily weight if they are acutely ill or inpatient, and they should weigh themselves regularly at home. Again, same time, same scale, with the same clothing. It's important to monitor any type of weight gain that might be related to fluid. A thorough medical history is also important, especially if there is a concern with the kidneys or kidney function or urologic of origin. Inquire about the client's drug use, both prescription and non-prescription or over-the-counter medications, as well as any possible drugs that might be taken recreationally. Inquire about the client's dietary habits or any potential dietary concerns. Assess the client's energy level. There is frequently fatigue and malaise with chronic kidney disease due to some of these systemic effects. Please review the chart 68.4 in your book. It goes over some signs and symptoms of chronic kidney disease in detail. I've listed some more common signs and symptoms that we often associate with chronic kidney disease. Here are some additional signs and symptoms from that list. But I encourage you to review that list in its entirety. Chronic kidney disease affects their entire lifestyle. So there is a definite psychosocial component to chronic kidney disease. It's important to make note of any type of anxiety or fear the client may have, what type of coping mechanisms and support system that they'll have. Chronic kidney disease may affect their social lives, their ability to work, as well as an altered body image. They may have limitations with what they're able to do, and sometimes kidney disease may lead to permanent disability. There may be limitations on their ability to socialize or have social activity, their ability to work. Typically, if they're end-stage renal disease, they are considered disabled. It also has an altered body image due to some of the associated factors with chronic kidney disease. It's important to review the client's diagnostics, and that's going to include the labs as well as any images. Labs may include BUN, creatinine, electrolyte panels, as well as urine tests, as well as that GFR that I talked about earlier. Imaging may include x-rays, kidney, or even CAT scans. Once your data is collected from your assessment, you begin your analysis or interpreting that data and looking for any potential issues or concerns with your clients. Once you've analyzed your data, it's time to plan and implement your nursing interventions and respond to your client's needs. Clients who are at end-stage chronic kidney disease or end-stage renal disease often have to go on hemodialysis or some form of dialysis. It's a kidney replacement therapy. They often have to be anticoagulated to prevent clots. They have to have additional vascular access, which I'll go into detail here in just a minute. When the kidneys can no longer function, hemodialysis takes place of that. It helps remove the fluid and toxins from the body. Clients on hemodialysis typically go on a 3-time-a-week schedule. The process of dialysis requires really high volumes of blood flow, and normally the veins would not be able to tolerate that. So they have to have additional vascular access in the form of a shunt or a graft or some type of a catheter. The photo on the top right is an arteriovenous fistula, and on the bottom right is the arteriovenous graft. They are both placed for long-term vascular access for hemodialysis. This slide shows a less common external AV shunt, as well as a femoral vein catheter, and that's in the middle picture. And those are done a lot of time in emergency situations, as well as the subclavian vein catheter, which you'll see more commonly for a temporary catheter. This is a photo of a fistula. It can take up to 8 to 12 weeks after being placed surgically before they're able to use. They have to mature first. There are certain nursing responsibilities when you have a client with a fistula. It's very important to review those responsibilities. This is another form of dialysis called peritoneal dialysis. These are typically left for clients who are a little bit more independent and have a better history of compliance. It's ultimately up to the nephrologist or the renal doctor on what type of dialysis the client gets. In peritoneal dialysis, similar to hemodialysis, it's still the process of diffusion, but it's a fluid that goes directly into the peritoneal cavity, and the peritoneal membrane acts as the dialyzing membrane and outflows the toxins and the additional fluid. There are a few methods of peritoneal dialysis, and it's really dependent on the client's ability and needs and their level of independence. Again, peritoneal dialysis is done at home typically, whereas hemodialysis is typically done in a type of a clinic setting. Just like hemodialysis, peritoneal dialysis also comes with its risks. Because they are accessing the peritoneal cavity directly, peritonitis is a huge risk of peritoneal dialysis, as well as tunnel infections, pain, and some other complications. Peritoneal dialysis patients are not too common in the acute care setting in the hospital. Again, typically they dialyze at home. But you do have to be responsible for your client if they do come in with peritoneal dialysis. That includes getting the vital signs, assessing weight, and monitoring the labs. A kidney transplant might be a life-saving measure for some clients that are in end-stage kidney disease that are undergoing dialysis. But there is strict criteria that they have to meet before this will be considered an option. And once they're on the list, it generally takes anywhere from 3 to 5 years to get. This is a photo rendition of a right kidney transplant. You can see it there just below the iliac crest. Post-operative nursing care for clients who have undergone a kidney transplant include urologic management. The client is likely to have a Foley catheter in place. They'll be assessing the urine hourly for at least the first 48 hours. They have risk for complications, and they'll be on immunosuppressants for a lifetime. Here are some potential goals for clients with chronic kidney disease. Remember, the evaluation and reflection is the final stage of the nursing process. If the client was unable to meet their goals, we may need to revisit our interventions to help a client achieve those goals. I will be posting an additional video that goes into more detail on the hemodialysis and peritoneal dialysis for you to view. This concludes the presentation on acute kidney injury and chronic kidney injury.